Hello, my name is Natalie Tuttle, and I'm one of the pharmacists here at University of Toledo Medical Center, and I wanted to talk to you today about opioid prescribing guidelines. So I have no actual or potential conflicts of interest in relation to this presentation. So my objectives for this presentation are to discuss the Ohio Opioid Prescribing Guidelines, to review acute pain prescribing guidelines, and to provide some information on Suboxone and methadone in the ER setting. As you all know, the opioid epidemic is a huge problem in the US and actually worldwide. Drug overdose are the leading cause of injury, death in the United States. A whole lot of people suffer from substance use disorders, and if you look at the number of prescriptions written in 2016, there was enough for almost one prescription per 100 people. So we're writing way too many opioid prescriptions, and we're definitely contributing to the problem. So in Ohio, there are some certain requirements that we must follow when we are writing opioid prescriptions. Every time, we need to check ORS if we're writing for any controlled substances. Here's the address for ORS. Everyone should also be registered for ORS. There are dosing limits on opioids. We need to make sure that we are providing the diagnosis codes on all the prescriptions. And we also have to make sure that we're having a day supply on all controlled substances and gabapentin prescriptions. So what is ORS? ORS stands for Ohio Automated RX Reporting System. It's a web-based system, and it collects information on outpatient prescriptions filled for controlled substances. So each prescriber who either writes prescriptions for controlled substances must register, or somebody who personally furnishes. So personally furnishes would mean that if you have a patient in the emergency room and you're going to give them a dose of morphine, you would also have to make sure that you're registered with ORS. And so you must make sure that we are requesting information on all patients for at least the last 12 months. It should be noted that when you do sign into ORS, the default is actually to look back 24 months, but you must at least, the law requires that you look back at least 12 months. There are some specific dose limits for the emergency department, so no patient can receive more than 7 days of opioids when they are sent home from an emergency department, so no more than 7 days of opioids for adults. If you have a child that you're writing a prescription for, no more than 5 days, but you also must obtain parental consent. No long-acting opioids, so no fentanyl patches, no oxycodone, so nothing that's long-acting. And then except as provided for in the rules, so there's a link down there for the rules, there are exceptions, but for the majority of patients, you cannot go over an average dose of 30 milligrams of morphine equivalent doses per day. So here's a table of some morphine equivalent conversion factors. So if we are looking at hydromorphone is 4 times more potent than morphine. So we would take our hydromorphone dose and multiply that by 4 to get our dose of morphine equivalent. Oxymorphone is 3 to 1. Hydrocodone, which we prescribe quite a bit, would be a 1 to 1. So if we want to figure out what our morphine equivalents are, we would take the conversion factor and we would multiply that out by what we're dispensing. So for example, if we had a patient that we were sending home on oxycodone tablets, we wanted that patient to be able to take it every 6 hours for 3 days. So we were going to prescribe them 12 tablets. So we would take 12 tablets over 3 days, because we're going to give them 4 tablets a day, times the 1.5, which is the conversion factor for oxycodone, and that would be our 30 daily morphine equivalent doses. There is a calculator that the board has developed, and it is online, and you can see the website there. It's actually very useful for being able to determine what your dose should be for when you're giving a patient a prescription for opioids. Ohio law also requires that prescribers include a diagnosis code on all of their controlled substance prescriptions. I just have a list here of some common codes that you might see when you're prescribing. There's obviously much more than this, but these are some common codes that you might be able to use just for future reference. Some other information that's just useful to know is that Ohio law requires the day supply on all controlled substance prescriptions and all gabapentin prescriptions. Federal law requires that you have it written both alpha and numeric. So if you're writing 30, you need to make sure that you put the numeric 30 and then also the word 30. Do not put QS or quantity sufficient on any controlled substance prescription. It's really a good idea to put a quantity on all prescriptions, not just controlled substance prescriptions, because the pharmacy does need to be able to calculate the day supply, and that is something that they would definitely call you about, and so it'll save them a phone call. If you have trouble calculating what the day supply should be, if we have a liquid medication or something like that, you can always reach out to pharmacy and we would be glad to help you with that. And just another note to just make sure that we're using caution if we're prescribing an opioid or a benzo in a patient that is known to use alcohol. We want to make sure that we are careful about our prescribing. So this was a notice that actually was sent out by the medical board. So just remember that the medical board is looking at your ORS history. The pharmacist in the emergency department definitely can look up the information for you, and we are glad to help you out. But if there is a decision to prescribe or personally furnish a controlled substance, you really should probably look that up on your account so that that history is there, because we want to make sure that you are not getting fined or have any actions taken against you for not looking up your ORS history. When this letter went out, the Ohio Medical Association took issue with the letter immediately and questioned how it could be that roughly 1/3 of Ohio physicians were in violation of the rules because they were not looking up the prescribing of opioids. So just be careful, make sure that we're looking up and that we're doing what's best for our patients. And while it may seem like a pain to check ORS every time when we are writing opioid or benzo prescriptions, it actually has been shown that just the use of ORS has helped decrease the number of patients receiving opioids. So the higher the usage of ORS, the less prescriptions of opioids and benzos. So this really does help protect our patients, and it really does help protect ourselves from prescribing to that patient that maybe is not appropriate. So I also wanted to provide you with some guidelines for acute pain prescribing. So if we're doing a pain assessment, we want to make sure that we're taking a medical history, doing a physical exam, making sure that we're taking pregnancy tests in female patients, checking the location of the pain, the intensity of the severity, the quality of the pain. We're also going to look at psychological factors and whether or not the patient has a personal or family history of addiction. We're going to work with the patient and the family to negotiate the goals of treatment. We're going to discuss risk benefits of non-pharmacologic and pharmacological therapies. And we're going to set realistic expectations for degree and duration of the pain. So we want an improvement of function to baseline. So we want to make sure that the patient can have function. I think that a problem that we run into is that patients may expect complete resolution of their pain, and that's not a realistic expectation. We should let them know that that's not always a realistic expectation, so that they are not looking for complete cessation of their pain, that it's more about getting to baseline function. So when we're treating that episode of acute pain, we want to make sure that we are utilizing our non-pharmacological treatments as well. We're using our heat, ice, we're using massage, we're using chiropractic, we're using biofeedback, we're using physical therapy. So we want to make sure that we are not just using pharmacologic reasons and pharmacologic treatments to treat our patients' acute pain. I thought this table was useful in prescribing the role of therapy depending on the quality of the patient's pain and some non-opioid measures that we could use to help with that patient's pain. So if we have a patient that has sharp stabbing pain, we could use a Tylenol, we could use an NSAID, we could use a corticosteroid. If we have a patient with neuropathic pain, we could give them a tricyclic antidepressant, we could give them gabapentin. So these are just some non-opioid pharmacological treatments that we can use so that we're not jumping to opioids all the time. So I wanted to switch gears a little bit and talk about Suboxone and methadone. So we have three possible scenarios that you might run into. You can have a patient that's coming to the hospital for a reason other than addiction, and they need to be maintained on their Suboxone and methadone. We have a patient that's coming to the emergency room strictly for their addiction, and we have a patient that's getting admitted for the sole reason of addiction. So for scenario one, if a patient is being admitted for a reason other than their addiction, for example, if they had an MI, any prescriber at all can write to maintain their maintenance dose of their Suboxone or methadone. So I want to just visit scenario two again, where a patient is coming to the emergency room strictly for their addiction. So an ED physician can order a one-time dose for their addiction. The reason that this is allowable is it allows that patient time to get into a detox clinic. The maximal allowable is one dose at a time for a max of 3 days. The patient would need to come back each day. You cannot write a prescription for them to have the 3-day supplies. And after they've had those 3 days, no more can legally be dispensed. So another thing that we must remember is that a patient was being treated already at a methadone or Suboxone clinic. You would not be able to tell this from their ORS history. So emergency department providers should not provide doses for patients in a methadone treatment program unless the dose has been verified and the patient's evaluation and treatment has prevented them from obtaining their dose. So the example would be if we have a patient that's on a methadone treatment, they came into the emergency room, and because of their treatment in the emergency room, they missed their daily dose. What we would need to do. So in conclusion, we want to make sure that we are checking ORS and we are checking it often. The medical board is looking at your ORS history. We want to make sure that we are doing our due diligence and we're doing what's best for our patients. Make sure that we're doing a complete history and physical when we have a patient with pain. We're doing a complete pain assessment, and we're also considering their psychological factors to their pain and whether or not they're at risk for addiction. We want to make sure that we are maximizing our non-pharmacologic and our non-opioid options. We want to make sure that we are saving opioids for our severe cases or patients that have ineffective alternatives. We want to make sure that we are doing the least potent opioid possible and the minimum quantity. When we are writing those prescriptions, we're going to make sure to write the diagnosis code on there and the day supply in both alpha and numeric. I wrote here no more than 3 days supply. That's just a good rule of thumb. The law is actually no more than 7 days for adults and no more than 5 days for children with parental consent. But when we're considering a patient in the emergency department that's fit to be discharged, this should be an acute process, and 3-day supply should be plenty to get them through until they can get their condition taken care of. So we want to make sure that we avoid opioids if the patient is also on benzos or on sedatives. We want to remember the federal 3-day rule when it comes to Suboxone or methadone. If we can get a patient into a treatment center and onto Suboxone or methadone for replacement therapy, it actually has been shown to reduce their risk of mortality. But we want to make sure that we're following the rules. No more than 1 dose at a time, 1 dose per day, no more than 3 days. After those 3 days, the patient is not allowed to get any more from us or from the emergency department. So if a patient has missed a dose, we want to make sure that we're following up with their clinic to make sure that their dose truly was missed before we dispense it in the emergency department. This slide is just some additional resources that you might find useful. So there's a link to the Ohio Mental Health and Addiction Services, Ohio Guidelines for Emergency and Acute Care Facilities, and then also the DEA information for emergency narcotic addiction treatment. So that's for those doses of Suboxone and methadone. So if you have any questions, my email is listed below. So please reach out if you have any questions or you need any clarifications. Thank you for your time.